So as part of the authority's statutory function, we have a role reviewing the regulators' fitness to practice cases, and sometimes to ensure that we have the appropriate information to use and to consider when we're looking at these cases, we commission research to support that process and often to give us insight into what the views of members of the public and professionals might be on certain issues. For example, we've previously commissioned research into dishonesty amongst health and care professionals. One of the things which my colleagues in the legal team observed from their experience in reviewing fitness to practice cases, particularly those relating to sexual misconduct, were that whilst panels often treated cases of misconduct between professionals and patients as being very serious, there was often a different approach to cases that involved misconduct or breach of boundaries between colleagues. They felt this was an interesting finding because there was often a sense from both fitness to practice panels and from the courts when we took forward appeals to certain cases that such cases didn't pose either a direct impact to public safety or that the impact on public confidence was perhaps not as serious as cases involving patients. And so we felt that it was important to commission this research to explore what the views of the public and professionals were in relation to sexual behaviours between colleagues, for them to consider where the boundary might lie, and essentially to sense check our views here at the authority with those of the public to see whether our views were out of step or whether they were in line with public opinion on this issue, and to consider what the implications might be both for our approach and for the approach of the regulators that we oversee.
We feel that this type of behaviour, whether in relation to patients or in relation to colleagues, is indicative of potentially deep-seated attitudinal issues at worst or poor judgment at best. Because fitness to practice extends beyond the clinical sphere and into how you conduct yourself in relationships with your colleagues, these types of behaviours are relevant to someone's day-to-day practice and how confident colleagues are in working with them, and also for the person who's potentially the victim, how they exercise their clinical duties on a day-to-day basis, because they may feel nervous or not wish to be in the same room as the person who has been crossing boundaries with them. Our experience of reviewing the final fitness to practice decisions has been that panels tend to minimise the seriousness of this behaviour because there is no obvious patient harm. Our view is that this is the wrong approach, and that the fact that there is no patient harm should be a neutral factor as opposed to a factor which is taken into account in terms of mitigation for the registrant. We've also seen panels refer to what they call as a culture of banter, and in effect allowing or normalising this conduct within the workplace environment, and again reducing personal culpability in relation to this. So where panels seem to be taking this kind of behaviour less seriously, it can affect public confidence because the public may feel that the registrants are not being held to account for their actions, and it may prevent victims from coming forward and bringing these types of complaints to the regulator's attention.